In today's lecture, we are going to discuss the receptors of the parasympathetic nervous system with a special focus on muscarinic receptors. We'll break down their subtypes and understand how each of them acts on different organs. Before we begin, I strongly recommend watching the introductory video on the autonomic nervous system if you haven't watched yet. This lecture is directly connected to that foundation. Let's get started. In our introductory video on the autonomic nervous system, we understood the functions of the parasympathetic and sympathetic systems through a simple analogy. Imagine a big dog suddenly starts chasing you. Instantly, your heart rate increases, your breathing becomes faster, and your body prepares for action. That is the sympathetic system in action, preparing you for the fight or flight response. In contrast, imagine you are sitting comfortably after a meal, relaxed, with no stress around you. In this situation, the parasympathetic system takes control of your body, and it slows the heart rate, activates digestion, increases secretions, constricts the pupils, and places the body in an energy-conserving state. These effects do not happen magically. They occur because acetylcholine is released from parasympathetic nerve endings and binds to muscarinic receptors present on target organs. When acetylcholine binds to receptors in the heart rate slows down. When it binds to receptors in the salivary glands, secretions increase. And when it binds to receptors in the eyes, the pupils constrict. So if we say activation of muscarinic receptors slows the heart rate, or in other words, that parasympathetic stimulation slows the heart rate, both statements mean the same thing because parasympathetic effects are mediated through acetylcholine acting on muscarinic receptors. Therefore, instead of memorizing each receptor effect separately, if we clearly understand the physiological actions of the parasympathetic system, we will automatically know what receptor activation will do in a particular organ. In simple terms, receptor activation is just the mechanism through which the parasympathetic system produces its effects. Now, if this concept is clear, let's move forward and talk about the different types of muscarinic receptors. But before we go into subtypes, I want to briefly summarize the overall muscarinic response in the body. If we look at it broadly, there are three major effects. First is on the heart, where parasympathetic stimulation slows the heart. Second is on the glands, where it increases all the secretions. Third is on smooth muscles, where it causes contractions. So, the big three parasympathetic responses are cardiovascular depression, increased secretions, and smooth muscle contractions. Muscarinic receptors are not just one single receptor. They are divided into subtypes like M1, M2, M3, and even M4 and M5 are present. However, from a clinical and exam point of view, the important ones are M1, M2, and M3. There is one more important point to remember. Most muscarinic drugs are non-selective in their action. That means a single muscarinic agonist does not choose only one subtype. It will stimulate all muscarinic receptors throughout the body. Similarly, a muscarinic blocker will not selectively block just one subtype in most cases. It will block muscarinic receptors wherever they are present. So whenever you give a muscarinic agonist, you should expect a combination of effects: slowing of the heart, increased secretions, and smooth muscle contraction all together. The same is true for blockers. Always keep this broader picture in mind. Now let's move forward and discuss muscarinic receptors organ by organ, starting with the eye. In the eye, there are two important muscles controlling the pupil: the circular muscle, also known as the sphincter pupillae, and the radial muscle. The circular muscle is under parasympathetic control, while the radial muscle is under sympathetic control. The receptor present on the circular muscle is the M3 muscarinic receptor, and on the radial muscle, it is the alpha-1 receptor. As we already know, parasympathetic stimulation causes meiosis, meaning constriction of the pupil, allowing less light to enter the eye. So logically, activation of M3 receptors produces meiosis by causing contraction of the sphincter pupillae muscle, which constricts the pupil. At the same time, the ciliary muscle of the eye, which is also under parasympathetic control, which also contains M3 receptors. The function of the ciliary muscle is to adjust the shape of the lens. When it is in relaxed state, lens remain flat, helps in focusing the distant vision. But when it contracts, the lens becomes more convex, more rounded, which helps focusing the near vision. This change in the shape of the lens while shifting focus between distant and near objects is called accommodation. So during parasympathetic stimulation, the sphincter pupillae muscle contracts, producing meiosis and reducing the amount of light entering the eye. At the same time, the ciliary muscle also contracts, changing the lens from a flat to a more rounded shape, allowing light to fall properly on the retina and enabling clear near vision. Suppose if the pupil constricts but the ciliary muscle does not contract, the lens would remain flat and the image would not focus correctly on the retina, resulting in blurred vision. Therefore, both pupil constriction and lens thickening occur together in a coordinated manner, and this process is called accommodation. In this way, M3 receptor activation directly produces the typical parasympathetic response in the eye. So clinically, a muscarinic agonist drug like pilocarpine is used in conditions like glaucoma, especially angle closure glaucoma, where the intraocular pressure is elevated. In angle closure glaucoma, the problem is mechanical blockage of aqueous humor outflow. Normally, aqueous humor is produced by the ciliary body and then it drains through the trabecular meshwork. In angle closure glaucoma, the peripheral iris moves forward, and by that, it physically blocks the trabecular meshwork. So aqueous humor cannot drain properly, but production continues. The pilocarpine drugs stimulate M3 receptors. They cause contraction of the sphincter pupillae and, more importantly, the ciliary muscle. The contraction of the ciliary muscle helps open the trabecular meshwork, which promotes the drainage of aqueous humor. As the outflow increases, the IOP decreases, helping to protect the optic nerve from damage. In the heart, as we have already discussed, the parasympathetic system slows the heart. So whatever receptor mediates parasympathetic activity in the heart must produce that same effect when stimulated. The predominant muscarinic receptor subtype in the heart is M2. These receptors are coupled to the GI protein, and when acetylcholine released from the vagus binds to them, GI activation leads to a decrease in cyclic AMP levels and an increase in potassium efflux. Because of increased potassium efflux, the pacemaker cells become hyperpolarized. This hyperpolarization slows the rate of spontaneous depolarization, ultimately leading to a decrease in heart rate, which is the principal parasympathetic effect on the heart. M2 receptors are highly concentrated in the SA and AV nodes and to a lesser extent in the atrial myocardium, but not significantly in the ventricles. That is why, when the parasympathetic system is stimulated, the most prominent effect is a marked decrease in heart rate due to its action on the SA node. This is called negative chronotropy. At the same time, conduction through the AV node is significantly slowed, which we refer to as negative dromotropy. Because the ventricles have very few M2 receptors, there is minimal effect on ventricular contractility, meaning parasympathetic stimulation does not produce a significant negative inotropic effect on the ventricles. This same mechanism of M2 receptor stimulation and slowing of the heart is seen in a condition called vasovagal syncope. In vasovagal syncope, there is a sudden increase in vagal tone. That means excessive acetylcholine release onto M2 receptors in the heart. This excessive stimulation will cause a sudden and significant drop in heart rate. Often, this is accompanied by a fall in blood pressure. Because of this combined effect, blood flow to the brain temporarily decreases and the person faints. That is why some individuals may lose consciousness during intense pain, emotional stress, fear, or even prolonged standing. all of which can trigger an exaggerated vagal response. Now, let's move to the lungs. As we already know, in the resting state, the demand for oxygen is reduced. So the role of the PNS in the respiratory system is to reduce airflow demand. It does this in two main ways. First, it causes bronchoconstriction, and second, it increases secretions within the airways. So the muscarinic receptors in the lungs are primarily located at two important sites on the smooth muscle of the bronchi and bronchioles, and second on the mucous glands. The predominant receptor subtype here is the M3 receptor, which is GQ coupled. When acetylcholine binds to these M3 receptors, through GQ activation, intracellular calcium levels increase, leading to contraction of bronchial smooth muscle, resulting in bronchospasm. At the same time, stimulation of M3 receptors on the glands increases mucus secretion. So stimulation of M3 receptors in the lungs leads to bronchoconstriction and increased mucus production. This pattern resembles what we see pathophysiologically in conditions like asthma or COPD, where the airways are already narrowed or inflamed. Because of this, muscarinic agonist would worsen airway obstruction and is therefore contraindicated in these patients. On the other hand, antagonists are used therapeutically. By blocking M3 receptors, they prevent bronchoconstriction, reduce airway resistance, and thereby help improve airflow. Now, let's move forward to GI and GU tracts. The main goal of the PNS is to promote elimination. In simple terms, it helps the body to poop and pee and also helps in the digestion of food. Starting from the stomach and intestine, parasympathetic stimulation increases peristaltic movements, which push food forward along the digestive tract. It also increases the contraction of intestinal smooth muscle, which facilitates digestion and ultimately promotes defecation. At the same time, for proper voiding to occur, the sphincter must relax. So while the smooth muscle of the gut wall contracts, the relevant sphincter opens, allowing the contents to pass out smoothly. A similar mechanism operates in the urinary system. Parasympathetic stimulation causes contraction of the detrusor muscle of the bladder and relaxation of the internal urinary sphincter. This coordinated action increases bladder pressure and allows urination to occur. Along with this, the PNS also significantly increases secretions in the GI tract. It stimulates the salivation, increases gastric acid secretion in the stomach, enhances pancreatic enzyme release, and promotes intestinal secretions. All of this helps in digestion and the smooth passage of food. So these parasympathetic effects in the GI and GU tracts are mediated primarily through muscarinic receptors, especially the M3 subtype. These M3 receptors are GQ coupled and are present on smooth muscles and on glandular tissue. When acetylcholine binds to these receptors, it leads to an increase in intracellular calcium. This rise in Ca2+ causes smooth muscle contraction and stimulates glandular secretion. So in the GI tract, M3 activation increases peristaltic movements, enhances intestinal contractions, and stimulates digestive secretion. At the same time, it promotes relaxation of the sphincter, allowing defecation. Similarly, in the urinary bladder, M3 receptor stimulation causes contraction of the detrusor muscle and relaxation of the sphincter, which ultimately facilitates urination. In addition, M1 receptors are also present in gastric parietal cells. These M1 receptors are also GQ coupled, so when stimulated by acetylcholine, they help in the secretion of gastric acid. Clinically, during excessive parasympathetic stimulation, for example in cases of emotional stress, GI irritation, or food poisoning, there is excessive release of acetylcholine, and ultimately M3 and M1 receptors become overstimulated. As a result, intestinal motility increases significantly, secretions rise, and the sphincter relaxes. Clinically, this can lead to abdominal pain, loose stools, or diarrhea. In the urinary system, excessive M3 stimulation may result in urinary urgency or even urinary incontinence. At the gastric level, stimulation of M1 receptors on parietal cells increases gastric acid secretion. If this stimulation is excessive or prolonged, it can contribute to conditions such as peptic ulcer disease due to increased acid production. As M3 stimulation increases gut motility and can even cause diarrhea, one might wonder whether we can use this same mechanism to treat constipation. Theoretically, the answer is yes, but clinically, we do not commonly use muscarinic agonists for constipation. For example, bethanechol is a muscarinic receptor agonist. Although it stimulates muscarinic receptors, it is mainly used for urinary retention or neurogenic bladder rather than constipation. The reason is something we discussed earlier in this lecture, that is, muscarinic receptors are non-selective in their distribution. A drug like bethanechol does not stimulate only the M3 receptor in the intestine. Rather, it stimulates muscarinic receptors throughout the body. So if we try to use it for constipation, we would also produce unwanted systemic effects such as bradycardia, bronchoconstriction, excessive salivation, abdominal cramps, peptic ulcer disease, and even urinary urgency. That's why, instead of muscarinic agonists, we prefer safer and more targeted laxative therapies for treating constipation. If excessive muscarinic stimulation causes diarrhea, abdominal cramps, urinary urgency, and incontinence, then logically, blocking these receptors should produce the opposite effect, and that is exactly how we use them clinically. In the GI tract, muscarinic antagonists reduce smooth muscle contraction and decrease secretions. This can help relieve intestinal cramping and hypermotility. That is why anti-muscarinic drugs are sometimes used in conditions like irritable bowel syndrome or acute intestinal spasms to reduce pain caused by excessive contractions. In the urinary system, blocking M3 receptors relaxes the detrusor muscle and reduces involuntary bladder contractions. This is particularly useful in overactive bladder, where patients experience urgency, frequency, and urge incontinence. By blocking muscarinic receptors, we decrease unwanted bladder contractions and improve bladder control. Similarly, at the gastric level, blocking muscarinic receptors reduces acid secretion. Although today we prefer proton pump inhibitors and H2 blockers for peptic ulcer disease because they are more targeted and effective. Just like muscarinic stimulation is generally non-selective, muscarinic blockade is also usually non-selective. So why do we still use these drugs beside their non-selective nature? As stimulation of M receptors produces bradycardia, bronchoconstriction, excessive salivation, diarrhea, sweating, and increased gastric acid secretion. Now ask yourself, do we actually want these effects? Or in how many common diseases do we need a slow heart rate, narrow airways, and loose stools? The answer is very few. That is why direct stimulation is rarely useful in routine clinical practice. On the other hand, blocking M receptors can be useful. For example, in asthma or COPD, as blockade causes bronchodilation and improves breathing. In bradycardia, blockage increases heart rate. In intestinal spasms, it reduces cramps. In peptic ulcer disease, it decreases gastric secretion. In overactive bladder, blockade decreases involuntary detrusor contractions and improves urinary control. That is why M antagonists are used more commonly than agonists. We use blockers despite their non-selective nature because in many conditions, the therapeutic benefit in the target organ outweighs the manageable side effects. Also, in clinical practice, we often use lower doses, local administration like inhalers for COPD or short-term therapy to limit systemic effects. So even though the drugs are non-selective, careful use makes them clinically valuable and relatively safe. Now, let's move forward and discuss the glands. Parasympathetic stimulation generally increases glandular secretions, including salivation, lacrimation, sweating, and other exocrine secretions. In most glands of the body, the predominant receptor subtype is the M3 receptor, which is GQ coupled. The main exception is the stomach, where M1 receptors also play an important role in gastric acid secretion. So overall, muscarinic activation increases secretions. Since muscarinic stimulation increases salivation and lacrimation, it can be useful in conditions where glandular secretions are reduced. For example, in Sjogren syndrome, where patients have dry mouth and dry eyes, and in patients with severe dry mouth after radiation therapy to the head and neck. In such cases, drugs like pilocarpine and cevimeline, these drugs are muscarine agonists, result in increased salivation and lacrimation. But keep in mind their non-selective nature. That's why we used carefully and in controlled doses. In some situations, local administration, such as topical pilocarpine in the eye, helps minimize systemic side effects.